Clinicians spend roughly 2 hours on EHR data entry for every 1 hour of direct patient care. That's this year, 2026. AI can and does solve that for doctors, therapists, and nurses, but the problem is getting the tech to where it needs to be. In a survey from the Digital Medicine Society, 72% of healthcare leaders said workflow integration is the single biggest barrier to AI adoption, ahead of training gaps and leadership waffling. Today's guest is fixing exactly that. His company, Vim, builds the rails that carry AI straight into the point of care tools where clinicians already are, so they can give those 2 hours back to patients and not paperwork. Welcome back to Humanify Health Tech, where we explore how AI is writing the rules of healthcare and putting people back at the center where they belong. I'm your host, Brian Chee, Senior Director of Content at NetHealth. Today, I'm joined by Oron Afek, co-founder and CEO of Vim, a digital infrastructure company that clears the path for value-based care by connecting physicians, payers, and developers in a frictionless AI-powered ecosystem that delivers real impact at the point of care. Before Vim, Oron served in the special forces of the Israeli military and built 4 companies in telecommunications, gaming, real estate, and education. Interestingly, not healthcare. He says he went into healthcare to make an impact and as such built Vim to run less like a typical health tech vendor and more like Uber or Amazon. Oron, thanks for joining us today.
Thanks, Brian, for having me. Excited to be here.
Good to have you. You've said that you've built Vim to run less like a typical health tech vendor and more like an infrastructure other people build on top of. What did that instinct come from? What was it about healthcare specifically that made you think that was the missing piece?
Yeah, it's a good question. I think the initial incarnation of Vim started back in 2015. And the original premise was, we would start with a patient-facing intervention. We actually called it BookMD before Vim was even the formal name. And we would allow patients to select care in places that are more, I would call them high value, which is lower cost, better outcomes, or similar outcomes. And the premise was if we can make it as easy as shopping on Amazon, people would change their behavior, use a platform that can lead them to a $300 versus a $3,000 MRI scan with the same, 5 Tesla MRI machine with even maybe the same radiologist that reads the same image. In the morning they're doing this in a freestanding facility called Glendale MRI. In the evening they'll do it at Cedars-Sinai for 10x the cost. That original premise, we thought, we start with modalities of radiology. We would then go and expand it to minor surgeries, colonoscopies, and so on and so forth. But starting from a place where there's usually abundance of supply, like imaging, very low variation, relatively low variation in outcomes, and obviously very high variation of price. That's kind of where we started. So similar thesis to what Amazon started with books. Again, inventory is not a constraint. You can just print a book on demand and just ship it out. And there's a huge selection of books. So similar thesis to how we started. We knew that this thing would have means to an end. Like once we are able to, conquer imaging, we can go to other services. That was the thesis. It failed miserably. And the reason that thesis failed or the experiment failed is that we've realized that patients, no matter if you empower them with online bookings and the ability to see prices up front, even to waive their copay, people would still going to be following providers' advice on not just what to do, but where to go. And that's something private equity firms realized a long time ago, where they started to fund health systems to start purchasing clinics, because they knew that if those clinics can start referring to those health systems and bypass, limitations such as Stark and anti-kickback, just through sheer ownership, they could really benefit from, um, you know, uh, more volume in more expensive settings and much larger negotiation power with insurance companies that will pay them 3 or 4x Medicare fee that would otherwise a freestanding facility or a small clinic wouldn't get paid for. So we realized that we can't really break referral patterns by facing the patient. And that's how we evolved into the physician side. That was the first pivot, the first major pivot. Um, the second major pivot happened when we realized that what we have done by in that case was guiding referrals to go to the more appropriate specialist by surfacing an incentive and data about where the PCP should be considering referring the patient. And that's actually been pretty helpful in altering referral patterns. We realized we actually stumbled upon, intentionally or unintentionally, on a key technology component that everyone is going to be needing, which is integrating with clinical workflows in a seamless way. And once we realized that, maybe just like Amazon realized that they're sitting on a lot of compute that maybe is required in December during Christmas, but in January again, like they're not going to consume all this compute, and voila, you have AWS, right? We decided that opening the platform for third-party developers to then leverage everything we have discovered, that's going to be the right way to go. And that's what Vim does today. Vim is a developer platform that allows you to integrate with any workflow. By the way, administrative or clinical, we support today most ambulatory, acute, post-acute EMRs. We support other system of records such as CRMs, payer portals, ERPs, even a bespoke vibe-coded platform you built last night. You can support it for real-time read and write, as well as to present a bunch of UI or interfaces on top that allows either apps or agents to run. So that's the story in a nutshell.
So essentially, what Vim does, reading this back to you, is what Vim does. It allows vendors to live inside the provider's workflow and influence the care decision at the point of care, at the point where decisions are being made. Is that right?
Yeah, I would say in the last 6 months, the platform has been evolving to work, again, continues to support the point of care engagement when in the moment patient and providers are interacting. So that's majority of our use cases today. But we also now supporting other call them server to server or backend use cases, such as, someone calls in at 2 a.m. they want to schedule an appointment. Not a problem. We can support those type of use cases. Here's a list of 100 patients. Reach out to them, call them, get them scheduled for an office visit, a wellness visit. Prepare me for the visit itself. Create chart prep materials. Automate the order. Post encounter. So we did expand the platform capabilities, but the point of care was the initial nucleus of this.
So a patient, let's say a patient is at the doctor's at their PT at a doctor's appointment. That doctor's using ambient documentation. The notes that are being created are then almost instantly being referred through your system to inform on treatment and a decision, payment, all the things aligned to value-based care that need to happen in order to keep the treatment happening in real time and giving the provider the decision-making power at that point. Then after that, to what you just said, it's about aligning the tactics of making those appointments and getting the patient to the next appointment, all through your infrastructure. Is that right?
Yeah, these are great examples for building blocks that we have on our platform. There's obviously a lot more. Think about care management teams, payer side teams, MSO, ACO side teams that are not the clinician themselves, but they do interact with patients or interact with other administrative or clinical workflows. And yeah, you can basically build whatever you want.
So it's a powerful connection tool that actually empowers this powerful technology that is already available for providers to use throughout that entire ecosystem. That ecosystem, by the way, is something that I want to ask you about because you referenced it. You referenced it on a podcast, and I want to bring this up because I thought it was kind of funny, but also very true. One of the things you talked about regarding sort of healthcare and the system in relation to the first wave of EHR digitization was that health systems didn't design how care worked. When it came to EHRs, they just digitized the broken workflow that was already there. And you called that paving the cow path, essentially taking a cow path, slapping some asphalt on it, and basically saying, see, isn't this better? No, it's not better. So that doesn't solve the problem, right? But maybe AI does. Is AI in relation to what Vim does a way to actually turn those cow paths into an actual regulatory path that works in a real time basis?
In order for generative AI to genuinely help, not just administratively, but also clinically, it needs to understand the broader context of who's that patient, what's the benefit design, what's the plan information, what's the broader clinical information that is available about that patient. A lot of those data sets could be assembled, you know, at a given moment of time, but need to be updated. Some of those data sets can only be assembled once you justify treatment, which is the patient is actually scheduled and is about to get to the clinic. And then you can start pulling data from the broader health information exchange or industry, right? So essentially, you need to make sure that the data is available and is standardized and down to a markdown version that agents can interact with in real time, and that the right users can access the right data for the right patient at the right time. So there's a complex entity store that needs to govern who can access what and under which permissions and who signed a BA with whom, whether it's a third-party developer or a payer or risk-bearing entity or Medicare itself, or the physician is saying a cash paying patient or someone that is complaining about a mental health condition should be hidden from the payer because that condition is being paid for with cash because the patient doesn't want this thing to leak to their employer. So there are a lot of permutations and limitations of how you need to get data, sanitize data, making it available, and again, right data portion to the right user at the right time. Once you have that foundation, then enabling things like agents to run data and start fulfilling things such as preparing a chart or suspecting for net new conditions or finding a clinical evidence for a known condition from last year that you want to revalidate or creating a care plan, right? Those things become a lot easier now, but still need to be done, right? The third portion of this is actually how do you, again, okay, fine, you read things, but then how do you write them back into the system of record? That's the regulatory piece, Brian, you're talking about, which is you need to make sure that the information, whether the information we found or the net new derivative that you've created, like a care plan, those need things to travel back into that EHR and be documented for the purpose of, let's say, Medicare audit, for other ONC governed elements of how those EHRs were structured. And when you can do all three, as we can do, I think you can genuinely and truly start benefiting from the value of AI, right? So think about automation, building skills, creating repeatable intervention for the same patient or similar cohort of patients, and do this in a way that doesn't require you to write code. You can literally vibe code or use simple English to create those skills that just like you would use Anthropic's Claude Cowork or one of those similar solutions. The problem we've been facing is that building everything I just said on a normal fire infrastructure or HL7 infrastructure was not possible. It wasn't possible because the APIs that were exposed and are exposed by different system of record vendors are not consistent, right? They're not consistent. They're very partial in places where, they've been made available. They've been made available with a lot of hurdles, such as Epic as an example. And everything needs to be done through that vendor priorities and that such vendors, kind of preferences and strategy and all that. So it did not create an ability to have a consistent way by which agents or apps can interact across the board and in a cohesive way. So you don't have enough context, you don't have enough way to execute, and you're just creating and you're overburdening the providers again. You can't automate things on their behalf, and you're still asking for more clicks. So what we've been able to do is to build a technology that is able to interact bidirectionally with those systems without reliance on the underlying system of record. And do that, by the way, in a way that doesn't use, sort of computer use agents or computer vision, things that would be by definition probabilistic. Do that in a way that is deterministic. Do this in a way that essentially we learn the workflow. We then create a layer of APIs on top, and then we allow agents and apps to interact with any clinical workflow consistently in a deterministic way, right? So it doesn't matter if the 100 different EHRs in an ACO. Once an app is being built, such ACO can operate across all the different clinics, employed or contracted, with the exact same app, with the exact same way of exchanging data and talking with a physician. So this component was the big, kind of breakthrough. And obviously everything on top is great, but this is the underlying, kind of magic that we've been able to sort through and build.
So this is do you think that this is what gets value-based care to work, that gets it to actually become more effective in our current system, in our current American system of healthcare?
I want to hope so, yes. I want to hope that value-based care can be AI first, can be AI native. Value-based care can be a paradigm where the humans work for the AI and not vice versa. I know it's a bit controversial, but let me explain myself. I mean that if the agents themselves are aware of what needs to happen, what needs to be quote unquote maximized, right? Data is in one place, actions can be synchronously written back and forth from system of records. And then you have the clinicians themselves that are the judges, the people with agency that decide that, okay, that's what this agent have recommended. Do I accept or decline it? Just like you do with your cowork before it takes on an action. I think that's the future of value-based care. Otherwise, it's going to continue to be a whack-a-mole game. And for the most part, people are going to continue to try to see if they can squeeze more dollars from uncovering more conditions or gaming the HEDIS system, one condition at a time without genuinely adding value to the system itself. So I think if you have AI tailoring the right intervention for the right patient at the right time, whether they're seeing a physician or not, by the way, but then you have the physicians acting as the gatekeepers for clinical decision making, I think can win value-based care. And to do everything I just said, you need to have infrastructure.
Right. But and so you're saying that essentially, I'm not going to fix the broken system. I'm actually going to use AI to adjust it and then build something on top of that that's better. Because AI is at that point, native AI is at that point where it could actually adapt to whichever system, like an Epic system or other systems or other environments, to standardize that approach and thus make value-based care possible across a broader swath of healthcare. Is that right?
Yeah, I mean, I think it's a really elegant way to define this. If we're thinking about those systems, it's basically a bunch of UI in a piece of software in a database in the most simplified way possible. And the UI is, it's more of the way I think about it is an API for the human brain, right? It's essentially like, it's not a very effective, maybe it's effective for us humans because, we think in a different way, in a certain way, but it's not the most efficient way for agents to navigate a piece of, a database, let's say. So by building a layer that is agent friendly on top of the system of records that circumvent the UI itself, again, allowing the physician to stand there in the middle, be the gatekeeper for clinical decision making, but do allow the agents to seamlessly interact both with the system of record, but also with endless other system of records, the SNF, the payer, the specialist, and so the patient, and so on and so forth, and get those things orchestrated. I think that's where the magic happens, right? Like the agent doesn't need to rely on UI. That's why there, as you said, there is something net new that's being built on top, allowing those agents to interact. Eventually, the agents become the interface. At the end of the game, the agent becomes database of record. I mean, those system of records would be eventually replaced by agents as well. I mean, the database is in by itself, right, currently regulated, and just like CRM systems like Salesforce, kind of build this really unique ways of storing data. Those things are evolve as well into agentic databases that can be, again, if the agent itself is the one that interacts with your wearables, with your behavior, with your specialist, with your SNF, with your payer, that agent become a lot smarter than the EHR. And that agent would replace the EHR eventually. And we are building our infrastructure to this type of future. This future, again, not going to happen tomorrow morning, but it's gradually going to evolve toward that era that system of records is going to be replaced altogether by agentic workflows. And, again, we need to be nimble enough and flexible enough to support things, in a gradual fashion. And that's what we do.
That is so exciting. It is so exciting to be at the cusp of that and listen to you talk about what that future could look like. Okay, so let's go back in time a little bit, because I want to talk to you about your reason for tackling, which is probably the hardest problem in the world, or one of the hardest problems in the world, the healthcare system in America, right? So you grew up in Israel under a single payer system. There were 2, 3 tightly connected HMOs, right? You have said in the past that the idea of a doctor there making a decision about full longitudinal data on a patient is unheard of. In the US, that's kind of the default, right? And the dichotomy between what you grew up experiencing in Israel and what you experience in the US made you think I can make an impact by being part of the solution when it comes to the way the US handles healthcare and the system that drives it. Is that right?
Yeah. For me, it was overwhelming, still very overwhelming to think about a healthcare system that is, forgot who said it, but not caring, not healthy, not a system, that is on a fee-for-service schedule, meets the patients usually when it's too late. That prevention is enforced through, one-time incentives or something that is, it is to some extent is prevention, but it's very limited in terms of the holistic view, where retention span of a patient is as low as a year and a half, 2 years. It's basically equal to the time you keep a job with a certain employer, and then you switch a plan. And Medicare churn is pretty high as well. So Medicare Advantage, and then when you think about the long-term view of a patient, either from provider lens or payer lens, there's no long-term interest in patient care. And in Israel, at least, you have, like, as you said, the 3 HMOs, Brian, but the average retention rate of a patient is around 17 years. So it's much closer to a Kaiser, which obviously in this country is able to get better results at lower cost, than it is to a fee-for-service system. So what you have eventually, you have the smartest, most capable physicians in the world and the best technology here in the United States meeting fee-for-service schedules and one-time encounters with patients. It just ends up being very expensive and not very effective, and that's why we're seeing subpar results to other systems. So for me, the thought was, can we leap, can we fix this to make it seem more like a single payer system, even though it's still going to be running on a fee-for-service rails? Which, by the way, single payer system like in Israel do have their own limitations, right? The government decides what the capacity should look like, and they're only going to buy the 9th MRI machine after the 8th MRI machine is booked for 24/7 solid. And by the way, these are the numbers that Israel does, at least used to be allowing to serve 10 million people, like 1 MRI machine per million. It's pretty nuts. So taking the free market dynamics that made this country so great, but putting the right infrastructure in place to genuinely allow for the right uh, care under the right incentives to happen. Now, I can't do everything, right? If I could, I would try to convince Congress to stop employer-sponsored healthcare, because I think it's a disaster, and double down on ECRA vehicles that allow for, more of a state-based coverage, which is going to be more long-term, right? But I can't affect those things. So at least what I could affect is putting all the players in the same infrastructure, on a common infrastructure, and allow them to play and interact in a way that is transparent and easy and simple, without being constrained by things that should be commoditized, like workflow integration. And you said it, like this is a big hurdle for AI adoption, for value-based care adoption. So that was the thought. Today, I think we can leapfrog the single payer system benefits and go into an AI payer system. And AI, the beautiful thing about AI, doesn't get tired, and it can be very specific, and it can tailor to the individual. And in that type of world, medicine becomes proactive, not reactive. And that's not something you have in Israel either, or Canada or Germany. A proactive healthcare system that is having a constant conversation with the patient, loops in physicians and interventions when needed, but it's definitely a different paradigm.
So it's essentially, you're saying it's keeping doctors from making decisions in that void, right? The void of information, the void of retention. They don't know who the patient is. They don't have the information about the patient. They don't know what the patient is able to do as far as treatment or the extent of their treatment. And they're making those care decisions. What's the term? Sick care decisions on that patient without having all that information at their fingertips. Essentially, Vim is trying to eliminate the void there so the doctor can make the right decision through the use of AI.
Yes, and ideally the doctors are part of large organizations, and we do lucky to work with quite a few of them that are physician aggregators that know how to adjudicate, quote unquote, the complexity of the payer with the reality of care delivery on the provider side. And we serve as their infrastructure in order to make care delivery more seamless. And I think that's a good way of kind of finding an interim solution to this adversary payer provider relationship that drove this single largest industry in the world.
Yeah. Okay, so you talked a minute ago about fragmentation. I think we touched on the sheer amount of differences in the system, the payers, Medicare, all the insurance companies that a health system that doctors have to deal with, right? That makes this an exquisitely complex problem. What does that cost a practice on a day-to-day basis? Not necessarily just in terms of abstract thought, but like as an actual wasted time or in helping patients heal, right? What is that picture what is the picture of what that fragmentation costs?
I mean, we can talk about today's terms or 3-year outlook terms. I think in a world where I think every individual physician is signing a contract with at least 10 different payers, and each one of those payers have at least 3 different lines of business, and essentially have 30 different sub payers, right? I mean, that's pretty fragmented. Each one of those payers have a different portal, usually. So 10 different portals, different rules to submit prior authorization, and different ways to reach you, need to cater for those patients, how you guide them through referrals, which specialists can you send them to. A lot of those questions, as you said, combine this with the administrative burden of documenting things in a certain way to get paid. You're looking at least half of the time is essentially invested in non-delivering value for patient, but just that's half of the time of those providers. And by the way, the physician himself are not the only one participating. You have the largest ratio of support staff per physician in the United States, and any other OECD country, which is pretty phenomenal. Take that and also count the externalizations. I'll give you one example of an externalization. Those externalizations are even more expensive than the sheer administrative cost in a given practice of a primary care physician. But an overburdened primary care physician practice, when they need to refer you to an MRI or CT scan, they would oftentimes elect not to even handle the prior auth submission process. And the reason is that they're overburdened, and you have large academic centers that surround them, and they know that those primary care physicians are overburdened, and they came there and they said, we would take it away from you. We would take care of that submission of prior auth. We have a full-blown staff that's going to call your patient, get the appointment scheduled, get the prior auth submitted, get it approved. We'll take care of all this for you, and we'll send you back the biopsy. If I'm a doctor and I'm already overburdened, that sounds amazing. Let's do it. What's happening at this time is that a patient leaves the primary care office, they're getting a phone number to call that academic center into their call center. That academic center would first schedule the patient for the MRI, that by the way costs between 6 to 10 times more than a freestanding MRI in a different facility. And again, just one modality. We can talk about every other modality. They would first schedule the patient. They would then get them to sign a waiver that if this wasn't covered by insurance company, in retrospective, they need to pay it out of pocket. Everyone just signed those waivers blindly. The third thing, they would then go ahead and submit the prior auth. In many cases, the prior auth is only approved after the fact, after the service was already done, or just before the service is getting done. So they have really good kind of perfect timing for how to do that. The externalization of this is that we end up paying for those MRIs, whatever, 6 to 10x more than we would pay in a freestanding facility, just because our PCPs are overburdened. And I can give you examples that go into pharmaceutical products and surgery, where the admit rights of certain providers are, and so on and so forth. It's the externalities of overburdening our providers is enormous, and that contributes tremendously to the cost of the system.
Wow. Okay. So let's talk about Vim a little bit and what Vim is doing currently. I think Vim has been around for about 11 years, I think.
Yeah.
You have close to 100,000 providers across 10,000 practices. They're live today. As I understand it, a developer can put a tool inside a doctor's EHR without having to sell that through to every single clinic. It works. The Vim works to put that tool, that vendor's tool, in the workflow of that doctor's office so that they can use it in real time. Is that right? So what does that look like? If that's true, what does that look like for the provider, for that doctor, for that therapist when that occurs? What actually happens there?
Yeah, for sure. So let me take a step back. So today, if you wanted to deploy an application in a given EHR, you need to go use case by use case, EHR by EHR. So for example, Vim has over 100 different apps built on our platform. No EHR would allow me to deploy them through a smart or smart on fire Rails into that specific practice, because nobody would allow you to build an app store in a single app, right? We have a full-blown app store that can be deployed. So it's multi-use case on any EHR. And that's a big difference, right? Go and try to deploy a smart on fire app with Epic for risk adjustment. Whatever, those 40 hours, quote unquote, that the net work that is going to take place is going to likely take 3, 4, 5, 6 months to accomplish. That's one site of providers. So one provider site at a time, one use case at a time. So our approach is all use cases at zero time deployed on any EHR. And that opens the opportunity for developers exponentially, right? Now, so build once, deploy everywhere across the Vim network, or bring your own providers. We have really easy for developers to invite net new providers to the platform. From a physician standpoint, initially it was, pretty compelling and simple, right? I mean, they, open up their EMR. We are context aware, so we see which patient is in context, what the physician is trying to do, and sending different API calls or queues to our developers to say, okay, it looks like your referral management solution or your ambient scribe solution or your prescription management solution is the right fit for this moment for this patient. Go ahead and surface it. Here's the notification. What happened is that over time, we had more and more developers joining the platform, and now we are seeing physicians starting to be overburdened with our own platform or with too many notifications, too many different apps, too many different options. So we are in the process of introducing an AI assistant that essentially is an app that can communicate with all the different apps through a single interface, just like a co-work, as an analogy. And he's able to, again, communicate with those apps on the provider's behalf and do things on the provider's behalf. And so the apps still remain, but the assistant becomes an interface that is allowing them to more easily navigate simple actions. And, you would see that happening in other, it's already happening in a, as I said, Co-work or ChatGPT. They do allow you to communicate with your calendar, with your email. So that's not very different. I think you're going to start seeing this really soon with Apple, and the new Siri is going to allow you to communicate with different apps without going to the actual app. I think you're going to start seeing more of that happening on consumer world. So we were taking a very similar approach.
So when I first started looking into this, I thought, this sounds like a marketplace almost, right? And then I started reading a little bit more. And what I'm coming to terms with is it's more like a massive communications network where Vim is actually sort of the translating all of the various inputs and all the various quote unquote languages that the different systems are using to standardize that language and to sort of create more efficiency as a result of that. Sort of that is that. I know it seems weird to think of it as communication, but listening to you talk right now, you're talking about an AI assistant that essentially is connecting all of the dots in terms of this kind of sort of app communication network. It's fascinating to me, really fascinating that is how we can use AI to simplify healthcare, simplify the process of healthcare, which is what it really is doing, right?
I understand. I think it's the right way to think about it. And when you have common infrastructure, common language, you can really allow for seamless communication. And those communication could be agents talking with other agents, with apps, with payer data, with the underlying EHR data. And that's what AI is so good at, which is taking those unstructured instructions and act upon them in a way that is that they can deliver value. But what we do is we're putting the right quote unquote evals in place to make sure that when the AI interacts with, let's say, clinical data or clinical workflow, they do that in a way that is deterministic and not probabilistic. So in a way that is safe. We don't want to have if you book the wrong flight, fine. But if you book the wrong patient for the wrong appointment, and it could be a disaster.
Yes, indeed. You've used a framework in the past. I think from an advisor to describe the near-term opportunity here for healthcare and in regard to AI. You call it offense instead of defense, right? Well, essentially what you said was, I've got it here. Hold on. Let me read this. This is important, right? Making providers more productive. You're going on offense to make providers more productive. Order automation, workflow automation, summarization, ambient scribing, all of that is included. The defense side of that is catching provider mistakes before they happen, which is what Vim does, right? That's all the AI that you have in Vim working alongside a clinician at the point of care. Walk me through how that works. Is there a consumer facing risk here in terms of that, or where, how in a real-time setting at point of care does that actually take place?
When I think about defense and offense, I think about AI adoption and how use cases are being adopted in healthcare, but also likely in other industry. The defense use cases are kind of the low-hanging fruit. It's like, you're about to do A, try to consider B or C because A is really risky, and here's why. So it's more of a, listening and proactively surfacing an option. Offense is kind of, thinking about more advanced use cases where the doctor is allowing the agents to go and operate on the provider's behalf. Oftentimes it's not like, hey, go take care of Brian, go talk with Brian, I'm too busy for Brian right now, or just, go talk with Oron, I'm too busy for Oron. That's not that type of offense. That's like 5 years away. Offense in a sense that, like, here's what I think that we should do, go and do it for me. Automate this order, get this prescription, get this car being ordered like it's covered by that patient's benefits. That's kind of how we think about defense and offense, and how the use case is being adopted gradually. And you need to meet providers and health systems where they are, and you need to understand where in the adoption curve they're at, and how much they're willing to take on in terms of the behavioral change. And that's the idea behind this.
So you've talked about impact, and I started the podcast talking about how you started 4 businesses, then you went into healthcare, and sort of said, well, that's interesting. Like, most people don't go into healthcare after being successful starting 4 businesses, right? I can understand why you do that now, because you're a visionary looking for a solution, or at least you seem to me to be this incredible visionary looking for a solution and making an impact. What was that impact that you were looking for that became Vim?
I think for me personally, and my co-founder likely have his own view, but for me personally, it was fixing the injustice that I think is I think, look, I mean, as an Israeli moving to the United States, very grateful for a lot of the tech industry, the military industry, a lot of the things that have developed in Israel. They're pretty much attributed to the United States being the mentor, the shepherd, the financier of a lot of those industries, right? So coming here thinking, hey, there's maybe something I can bring to the table, because what really motivates me is this, I think, just pure injustice of how the system is structured and how people end up paying for this. When someone pays their deductible and then they are signing up for, I know, $1 million worth of service in a certain provider and saying, yeah, I already paid my deductible, so I'm not gonna pay the rest of this. You actually are paying for that. You're paying it through the next year's premium that is 7 or 8% more expensive. We employers pay for it. Like, we all pay for this expensive system, and I think that obviously that's unfair for again, patient affordability or lack of affordability is a place that is, I think it's playing in my head. It's playing into fairness. It's playing into human rights. It's playing into those type of things. So for me, coming in and try to make a dent and try to create impact that addresses those issues is really motivating.
So 11 years in, if I were to ask you in 5 years, what would you like to see? Where do you want to be? What would your answer be?
I think in 5 years, the first AI native health plan that thinks about both paying for patient care and rendering patient care is already using Vim to treat at least 1 million patients. And it's so efficient, and it leapfrogs all the other players out there. People that build a lot of or combine a lot of bespoke solution that don't speak with each other. That from an organization standpoint, they just have 100,000 people. They don't know each other, and they can't coordinate a single action properly. And now you have a team of 100 people that is super tight, that is leveraging agents and data to treat 1 million patients. I think that's going to happen in 5 years, and I really want to be enabling that.
Oron, thank you so much for showing us all of this, showing us your vision, showing us where we're going in the future, and what that hopeful, optimistic view is. You've made me excited to see how that unfolds. I think that could make real change to a lot of people. Mostly the reason for that is, it's putting tools that are already developed, that are good tools, that are transformative tools, where they need to be, so that providers, doctors can actually use them and make not only not only their lives easier, but their patients' lives more healthy and a little bit more preventive in terms of the care they give. Thank you very much for spending this time. I could talk to you for another hour and learn more and more and more. I'm so grateful for this time. I know you're busy though, so the problems you're solving, do not wait for anyone. We'll let you go and jump into our recap segment next. Thank you very much again, though, for joining us.
Thank you, Brian. Thanks for having me again. Celebrating.
All right, recap time. Here are the top 3 things I took away from my conversation with Oron today. First, distribution and depth are the same failure at 2 different stages. A good tool that never reaches a doctor doesn't help anyone. And a tool that's technically integrated into an EHR isn't the same as one that's inside the workflow. Vim's bet is that solving both, not just one, is what makes the difference. Second, the industry's own hype cycle assumes healthcare behaves like a consumer app. And Oron says that's usually wrong. Most health tech gets funded and built expecting people to download it and form a daily habit. Healthcare is a low-frequency behavior. That mismatch is part of why so many well-funded tools never get used. Finally, Oron grew up under a single-payer system where a doctor deciding without full patient history was unheard of. In the US, that's the default. His bet is that value-based care only works once the technology and the distribution to reach a doctor exist together, not the technology alone. And that should do it for today's episode of Humanify Health Tech. As always, thanks for tuning in. If you're joining us on Spotify or YouTube, we'd love to hear your thoughts in the comments, and don't forget to leave us a rating while you're there. Once again, I'm Brian Chee from NetHealth. I'll see you next time.